All right, welcome to today's Grand Rounds. We're getting a little bit of a latest start, but I think we'll be fine, and we've got some technical solutions here. We've had to do a workaround, thanks to Dr. Kadir here, who will be our slide advancer. I'm going to briefly introduce Dr. Leslie Zune, who is our speaker today. He's coming to us, I believe, from the Department of Emergency Medicine at Mount Sinai Hospital. He's going to be talking to us about the topic you see here, evidence-based evaluation and treatment of the psychiatric patient in the emergency department. He's got a lengthy CV, and I won't go into great detail on that. Just if you'd like to see it, it's available. And without further ado, I'll ask Dr. Zune to start his presentation for us. Thank you.
Well, thank you very much for having me today. And we're going to be doing this remotely, and I'm going to be asking the staff to advance the slides. So let me give a little background about who I am and what I do. I am the president of the American Association for Emergency Psychiatry, which is a group that advocates for the care of patients in the emergency setting, psychiatric patients. And we're a small organization, and I'll talk a little bit more about a couple things that we do down the road. I'm also system chair for emergency medicine in the Sinai Health System, as well as professor and chair of the Department of Emergency Medicine at Chicago Medical School, with a secondary appointment in the Department of Psychiatry. Next slide, please. To disclose, I'm the principal investigator for 2 research grants sponsored by Teva Pharmaceuticals, given to Mount Sinai Hospital for 2 interesting studies on agitation and psychic pain in the emergency department. The second is an Emergency Medicine Foundation grant for agitation research, where we're primarily looking for looking at treatment Adasuve use. Next slide, please. So there's really 4 objectives to this talk. One is to understand the medical clearance process. Second is, can we use protocols to make it easier in the process? We're going to talk about treatment and the role of verbal de-escalation and trying to improve choices of treatment modalities for psychiatric patients in the emergency setting. Next slide, please. So I'm going to bring up 2 cases to illustrate the points of the talk. The first one is a 64-year-old female who's brought to the hospital for manic behavior. She has multiple medical problems, but she does not have any psychiatric history. What further information do we need? And what do we look for in the physical exam? And if we are going to get testing, what testing do we need to get? Next slide. The second case is a 36-year-old male with schizophrenia brought in by the family because he stopped taking his medication and is getting violent at home. That sounds like a pretty similar situation that we see quite frequently coming into our emergency setting. And the same questions we have before: what further information is needed? What do we look for in the physical exam? What testing is indicated? Next slide. So why do we do medical clearance? There's 2 reasons we do medical clearance. One is to determine whether a medical problem is causing or exacerbating the psychiatric condition. This is really the issue of, is the patient presenting with a medical problem that needs a medical evaluation treatment, or is it psychiatric? The second is, like any other patient we might transfer or admit to the hospital, we need to understand what other medical or surgical conditions the patient has that is incidental to the psychiatric problem. But this may need treatment or at least evaluation before they can be transferred to another institution. Next slide. So what this slide tries to show, and I want you to focus on those 3 overlapping, like a Venn diagram with the 3 overlapping circles. So the big question in the emergency setting is this just a psychiatric presentation? Is this a medical presentation? Or is this drug intoxication or withdrawal? The problem is it may not be purely one, but in fact may involve all three. So if we look at the studies, we'll talk a little bit about these, there's a significant overlap. The number of patients who have chronic medical illness that have a chronic psychiatric illness, and the same is true for those that have a psychiatric illness. There is a dual diagnosis with substance intoxication or withdrawal. Unfortunately, the percentage is not well known. It's somewhere between 20 and 80%. I think 40% is probably the best estimate for that. So, but when we look at the list on the left-hand side, what I think about is probably the most important one to pick up is delirium. We don't want to miss delirium, and I'll explain why in a minute. Next slide, please. The reason we don't want to miss delirium, as you can see in this slide, is it has a high rate of mortality. If missed, it's about 36%. If it's picked up, the mortality is about 10%. And the biggest problem we have is it's not well detected in the emergency department unless it's screened for. And in this study of elderly patients, they found that the incidence was fairly high, between 7 and 20%. So it's something that we need to be aware of, and we need to pick up while they're in the department. And really, we'll talk more about how to pick it up, but the most important thing is basically these patients are behaving normally part of the time and have altered mental status part of the time, and it can alternate. And that's what we need to try to pick up. If they're acting normal when they're in the emergency department, we have to inquire, how were they acting before? Why did they come into the emergency department to begin with? Next slide, please. So how do we make this differentiation of medical from psychiatric? Well, we use a history, physical exam, mental status testing, a cognitive assessment, and we'll talk about how to do that in the emergency setting, and maybe testing, maybe not. Next slide. So what percentage of chronic mentally ill patients have a medical problem? Well, in this study of about 300 patients, about half of them, a little more than half, had a chronic medical illness. And the most common were hypertension, asthma, and diabetes. So when you transfer a psychiatric patient to another facility, we need to know whether that facility has the capability to do monitoring, maybe check glucose, provide some treatment or not. And so, for instance, in Illinois, we have 2 state psychiatric hospitals, and they are very, very limited in what they can do and the testing that they do. So we can rarely send diabetics or asthma or those kind of patients to that facility because of that limitation. Next slide, please. So what this slide tells us, and this was a study done a few years ago, about 300 patients, about 20% of them having a medical problem. The sensitivity, the most important thing we see is history. Boy, sounds just like medical school all over again, where history is the most important thing, followed by physical exam, vital signs in about 20%, and lab testing in another 20% or so. That's where it was picked up. Next slide, please. So the question here is, if the patient says they do drugs or alcohol, is that reliable? And if they say they don't do it, is that reliable? Well, at least according to this study, there's a high sensitivity and specificity for whether they say they do drugs or not, whether they do alcohol or not, and the testing that was done. So what this says to me is, except maybe in alcohol, people that say they don't do alcohol because it's not above 90%, it's 87%. we probably don't need to do testing. We can rely on the patient's history to tell us if they do drugs or alcohol. Next slide, please. So it's very important as we start thinking about the psychiatric evaluation, who does the psychiatric evaluation? So what we see is quite a various methods that occur across the country. Sometimes it's just a small emergency department, an emergency doc does it. Some have the luxury in-house psychiatry or ED mental health worker. Some use telepsychiatry. Some have outside services like community mental health comes in and evaluates the patient. The bottom line is whoever is physically there with the patient, whether it be emergency doc, psychiatrist, or anyone else at that level, needs to ensure that they're going to the correct place. Next slide. Now, I think that all patients in the emergency setting need a mental status examination, but they don't need the formal one that might be done on an inpatient unit. Rather, we can get appearance, behavior, and attitude, mood, and affect just by talking and looking at the patient. But the things that we can't pick up, that we have to ask about, are disorders of thought. Are they thinking about suicide or homicide? And remember, you won't see them to later go on to do that. Do they have insight and judgment? Do they know about their illness? And why is that important? That's important because if we're thinking about sending them home, we need to know that they have some idea about their illness and the importance of taking their medication. Disorders of perception. Sometimes it's easy. We see the patient talking to someone else or grabbing at things that aren't there, but sometimes we need to ask the patient if they're having hallucinations or delusions. And lastly, sensorium and intelligence. We need to know if they have cognitive impairment, and this will lead or can lead to the diagnosis of delirium if this cognitive impairment is something new rather than dementia that might be stable or slightly worsening over time. Next slide. I prefer to use the clock drawing test in the emergency setting. And the reason I like it is it's self-administered. I give it to the patient does it. It takes about a minute for them to do it. Either they get it or they don't. You can use scoring. I tend not to use the scoring. You can put it in the chart. You can document it. This is especially important if you have that little old person who says, I want to go home as soon as they come in, or there's nothing wrong with me. And we need to assess whether they can leave or not. So the other day I saw an elderly woman and I asked her to do the clock drawing test because she got brought in by ambulance. Her son called the ambulance but wasn't there yet. And as soon as she got in, she said, I want to go home. I said, draw a clock with 8:30. And she drew the clock on the top. She had all the numbers correct, but underneath she wrote 8:30. So I had enough evidence to keep her against her will. And in fact, she turned out to have neurosepsis and had a delirium state. And at the time I saw her, she was pretty together at that point in time. Next slide, please. So when we start talking about testing, we need to look at what tests are done and why. And should it be all patients or some patients? Should it be advanced testing or not? So most do some routine labs like a CBC, electrolytes, or CMP, urine drug screen, alcohol, and if it's a female of childbearing age, then we would get a urine pregnancy test. But if you look at the studies, routine testing, that's different than clinically indicated testing. Routine testing rarely changes the clinical management of the patient and is rarely helpful. And the same is true with drug screens and alcohol level. Remember I said before, most of the time we get all that information from the patient. Now there is one important indication to get drug screen and alcohol levels is when a patient comes into the emergency department with some altered mental status without a known etiology. Well, if the patient's sitting next to a bottle of vodka and smells like vodka and has nystagmus and slurred speech, I would say it's pretty likely that that patient has alcohol intoxication. So that wouldn't be indicated. But somebody, like I saw someone the other day that came in that had fallen into the L tracks and was acting bizarre. And we had no etiology for it. He needed a drug screen and an alcohol level, and in fact, he was positive for PCP. So when is advanced testing indicated? Well, one time I gave the talk and one of the psychiatrists said, well, you should be doing EEGs on all your patients in the emergency department. But in fact, what I found out is really no one does EEGs in the emergency department. But I do think that if we have a patient who comes in with new onset psychiatric illness, especially an elderly person, we should think about an EKG, CT head, chest, radiograph, those kind of things. So the next question is, should we do routine testing on everyone? Should we do routine testing on chronic mentally ill with the same presentation? Or should we do testing on those with new onset? And we'll explore that in a minute. Next slide, please. So according to the American College of Emergency Physicians, they have guidelines that say routine lab testing of all patients is of very low yield and need not be performed. In adult ED patients with primary psychiatric complaints, a diagnostic evaluation should be clinically directed by the history and physical exam. So that means clinically indicated testing. The APA has different guidelines. The APA says psychiatrists may need to request or initiate further general medical evaluation to address diagnostics concerns that emerge from the psychiatric evaluation. And in quotes, psychiatrists and emergency physicians sometimes have differing viewpoints on the utility of laboratory testing. Oh, this puts us at odds. We need to collaborate together, not to be divisive. Next slide, please. So let's talk about drug and alcohol testing. For again, going back to the American College of Emergency Physicians guidelines, they say routine urine tox screens for drugs in alert, awake, cooperative patient does not affect ED management and need not be performed. The patient's cognitive abilities rather than a specific alcohol level should be the basis on which clinicians begin the psychiatric assessment. Intoxication is a clinical diagnosis. Remember, you get a urine drug screen for marijuana, and it can be positive for up to 42 days. It doesn't tell us that they're clinically intoxicated today. Some of the lab tests only tell us that they have a metabolite from an earlier ingestion or inhalation or those kind of things. But rather, we should be determining intoxication on clinical grounds. What's their level of consciousness? What's their cognitive function? What's their neurologic functioning? Do they have coordination, problems with coordination, problems with gait? Do they have nystagmus? So those kind of things that will help us decide if the patient has clinical intoxication. Next slide, please. So this is a study done by Henneman a few years ago of adults. And what he looked at was new onset psychiatric illness. And what they found in 63 of 100 patients, there was a medical etiology for their symptoms. And most came up by history, a couple in labs. And it's very interesting. They did CT scan and LP in the 3 patients that came in with fever. And 2 of the 3 that came in with fever had herpes meningitis. So it's important that we consider that in patients like this that may come in with fever, because herpes meningitis does affect the temporal lobes, and you can see abnormal behavior associated with that. Next slide, please. So when is testing indicated? Testing is indicated when we have someone who is over the age of 45. There's a concern about toxins or drugs or intoxication or withdrawal. They have no prior psychiatric history, and maybe they do have a medical history as well. They have abnormal vital signs, a new cognitive deficit, focal neurologic findings, slurred speech, seizures, those kind of things. And also, as we talked earlier, any new onset of psychiatric illness needs extensive evaluation. And like I spoke about, in Illinois at least, we do accommodate the psychiatric facility or a consultation. So if I'm admitting a patient to the hospital and I call whatever admitting doc it is, and they say, well, I'm concerned about X, Y, and Z, will you add this lab or this radiograph or those kind of things, I would do that. But what we see would be no different than any other patient who I admit to a service. If a consultant wants a test, I'll get the test. Next slide, please. So one of the things that we can do to help this communication, to help the process, is a protocol. We developed this protocol in the emergency department in Illinois, together with the state of Illinois psychiatrists. And what we say here is, if the patient has a yes to any of the 5 questions, they probably need testing. So they have new psychiatric illness, an active medical problem needing evaluation, abnormal vital signs prior to transfer, abnormal physical exam, abnormal mental status testing or mental status indicating a medical illness. And if any of those are positive, the patient probably needs testing. And the important thing here also is that it's a way to communicate between the psychiatric service and the emergency service. Next slide, please. This term medically clear is somewhat of a confusing term. And in this study done by Tintinelli, she looked at about 300 charts a few years ago and found major deficiencies with a mental status in 20%. Doesn't surprise me. And most of the physicians use this term medically clear. The problem that I have is that these patients or this terminology medically clear, we don't know what it means. Does it mean I cured them of their medical problems? No, I'm going to be stabilizing. I'm going to be identifying and stabilizing their problems. So it should be replaced by a discharge note with a history and physical, mental status, lab testing, discharge instructions, some follow-up plans. But maybe what we really should be using is the term medically stable instead. Next slide. So let's go back to the 64-year-old female brought to the hospital for manic behavior. She doesn't have any psych history. She has diabetes, hypertension. She had an old CVA. She denies using drugs. When we examine her, she's tachycardic and hypertensive. She has an old right-sided weakness, and she seems to be talking really fast. So we're trying to understand what's going on with her. So she does need testing. And so she got a battery of tests. She gets an EKG, a head CT, a chest X-ray, everything. And what do you think this patient has? This patient turned out to be thyrotoxic. She had hypothyroidism. And that explained all her behavior and her vital signs as well. Next slide. We're back to the 36-year-old male with schizophrenia brought in by the family because he stopped taking his medication. He was getting violent at home. So he does have a prior psych history. He has no significant medical problems. He does admit to drinking from time to time. And his vital signs are normal. He admits to auditory hallucinations. His physical exam's pretty unremarkable. He has no signs of intoxication. And so is lab testing indicated? So one might say, no, we don't think any lab testing is indicated because, as I said earlier, the likelihood of having an abnormality is very small if we do a good history and physical exam. Now, while he's in the department, he gets more agitated. So the question is, how do we treat this patient? Next slide, please. So the first question you would ask is, do we know agitation when we see it, or do we need a tool, one of these scales, to help us determine at what level the agitation is? In fact, we're almost done with a study where we asked the patients to self-declare if they were agitated. And very interestingly, most of them, when they present to the emergency department, are feeling agitated. But remember, all the scales that we use are observational scales, and that has to reach a certain level of agitation before we can see it. So unfortunately, we have a deficit there, and I think we really need to think about starting the treatment much earlier. Next slide, please. This is a very interesting slide. It shows us two things. One, it shows us when the patient is most agitated. So we did a study. We did the agitation behavior scale, and we looked at when they're most agitated. Believe it or not, they're most agitated when they come in the door. And who wouldn't be agitated when you have 5 big burly guys running after you, bright lights, chaotic environment, somebody asking you a million questions? So it doesn't surprise me that they're most agitated when they come in. And again, we might have to question why, or maybe we need a better environment for them, maybe a quieter, dimly lit, less stimulus for many of these patients. And then the second thing this slide shows us, or this study shows us, is that about half of them were restrained. But it's very interesting, as you see in the red up there, 2 of the 47 were restrained. 2 of the 47 that were restrained were rated severely agitated. That means that 45 of the 47 didn't meet that criteria. And the reason, you might ask, is why then were they restrained? Well, we didn't study, but we think that they were restrained because the nurses were concerned about getting injured. And that's why the patient was restrained. And I'm not sure the Joint Commission would really find that to be an appropriate reason for it. Next slide, please. But we do need to treat agitated patients. Why? We think that it'll reduce their distress, because when we did our study about psychic pain and agitation, they are highly correlated. We want to prevent the progression of violence, because there is a high incidence of emergency staff being injured from agitated patients. Just like in abdominal pain, where we reduce their level of pain and we get a better evaluation, we think that if we reduce their agitation, we'll get a better assessment of their psychiatric condition. And the last reason is we think that we'll have a better therapeutic response. We'll begin the therapeutic process if we can actually work with them together and reduce this agitation. Next slide, please. So how do we treat patients that are agitated? We're going to talk about verbal de-escalation, physical restraint, seclusion, chemical treatment, and combinations of all the above. Next slide. So the first thing that we're going to want to do in almost every patient that comes in agitated is to try de-escalation. And to me, de-escalation is really just common sense. Give the patient some space. Don't be provocative. Establish some verbal contact. Try to be concise in our questions. The nurses tend to go, why are you here? Take off your clothes. Do you do drugs or alcohol? You're taking your medicine. Just too much. They have trouble processing information. We're better off asking them short questions and giving them a response, a time to respond. We need to identify their wants and feelings. Maybe they just need a telephone or food or someone with them to help calm them down. We need to listen to what they're saying, and sometimes we need to kind of set the law and give clear limitations. Next slide, please. So the Joint Commission and the Centers for Medicaid and Medicare Services say we have to do alternatives to restraints before we restrain someone. So we did a survey, a random sample of ED directors and psychiatric ED directors, those two groups, and asked them whether they used alternatives to restraints. And you know what? They all use them. There's not a whole lot of difference between the groups, but nobody thinks they're very effective. Verbal de-escalation, everybody uses it, maybe not effective. One-to-one observation, again, being used frequently, maybe not very effective. Decrease in stimulation, again, unsure of the effectiveness. Food or drink, everybody uses it or offers it, but we're not sure how effective it is. And we actually tried to do a study, but it's very, very hard to do a study of alternatives to restraints because you have to have an agitated patient, try one thing, do a washout, try another thing. You have to get them to consent. It's a difficult study to accomplish. Next slide, please. So we did a study looking at the complications from restraints because there was a concern years ago that all these people died from getting restrained. Well, actually, that came from the Harvard Courant, which was a newspaper expose, not a scientific article, where they looked at 140 patients that died from restraints, but they were all kinds of patients in psychiatric units, in emergency departments, in police custody, in nursing homes. Some were even hogtied. So we can't really use that as a good criteria. So we looked at complications after the new rules and regs. And in 1 year, this was a few years ago, 221 patients were restrained for about 5 hours. Most were supposed to be supine. Some had chemical treatment, shouldn't be chemical restraints added. And we saw about a 5% complication rate. No major complications, no death, no disability. The worst thing that happened is one of the emergency doctors, tore his biceps tendon. He was an old Navy man, strong guy, but that was the worst thing that happened when he went to restrain a patient. Next slide, please. We also did a study of seclusion use in the emergency department. We did a random sample of about 1,000 ED directors across the country. About 28% use them, so a fairly small number, but they were concerned about physical plan issues, safety issues, too many regulations, and so a lot aren't using them. We, in fact, thought about using them, but the biggest concern we had is the nurses were worried that because the door opened into the room, they were worried they get stuck in the room. Next slide, please. So we want to talk about medications, and these recommendations come from the American Association for Emergency Psychiatry. That's what I'm the president of. And a few years ago, we wrote we produced a 5-article consensus about how to evaluate and treat patients with agitation. It's in the Western Journal of Emergency Medicine. It is free access, so I'd recommend it's open access, so I'd recommend you take a look at them. If you Google agitation beta, you can pull it up. So in general, of course, we want to try non-pharmacologic approaches first to the agitated patient. We want to use medication tailored to the diagnosis. We don't want to give every patient the same thing because the etiology of the agitation may be different. And we'll talk more about that a little bit later. And the last thing is we should be doing some scale of the agitation and determining whether they need PO or IM meds, whether they need a smaller dose or bigger dose, depending on their level of the agitation. Now, there are first-generation antipsychotics that I'm sure you're familiar with, Haldol and droperidol. They have minimal effects on vital signs. They have a little bit of anticholinergic effect and not a lot of problems with interaction with other antipsychotic meds. They do both prolong the QT, especially droperidol, and that's why droperidol got a black box warning. There is a small number that get EPS or acute dystonic reactions, somewhere between 6 and 20%. We're not exactly sure. And it's recommended to avoid IV use because of the QT effect. Next slide, please. So now we're on to the second generation antipsychotics. So there are a number of different ones that are used out there: olanzapine, zyprasidone, Abilify, risperidone, etc. Some are given that there's been no head-to-head trials. What the FDA requires is that any of these agents to get approved needs to compare the agent to placebo, not to another agent, not to Haldol or anything else. So there's only a few studies that show any kind of consensus or significant findings. So risperidone is thought to be equal to Haldol with lorazepam given IM. If you want to give an oral agent, risperidone, haloperidol, and olanzapine are thought to be equivalent orally. And there's a few meds that are not recommended. Next slide. Now, this is getting to the question of we should be giving meds based on what the underlying etiology is for their agitation. So if they're coming in with recreational drug use, and that's why they're agitated, we'll go with benzodiazepines. If they take chronic amphetamines, then we'll consider like methamphetamine, like meth, a second generation antipsychotic plus a benzo. If they are alcohol intoxicated, we'll probably stay away from benzodiazepines because of a potential respiratory depressive effect, and go with either first generation or second generation antipsychotic. If they're an alcohol withdrawal, they need benzos and lots of benzos. Next slide, please. So for special populations, for instance, the pregnant woman, which I always find I end up taking care of a psychotic pregnant woman, there's always a question of what to safely give them. You can give them high potency conventional antipsychotics. Though all those drugs are in pregnancy class C, which means they haven't been tested. So we think it's okay, but we're not sure. And for kids, you can use benzos or atypical antipsychotics, butyrophenones. The issue is to stay away from antihistamines. I still see antihistamines given, but the biggest problem, both with kids and elderly, is the problem with the paradoxical excitation instead. Next slide, please. So how do we treat that agitated, elderly, demented, psychotic person? And the problem is there's a black box warning for all antipsychotics. And all the drug companies wanted to be the first one on the block to get approval for their drug because there's so many elderly in nursing homes that have sundowning syndrome and are disruptive. And so everybody wanted to do that. So the FDA looked at the studies, and the studies of antipsychotics, the new antipsychotics, the atypical antipsychotics, were higher than placebo. But when there was a study done in Canada looking at Haldol to the atypicals, and Haldol actually had a higher mortality rate than the atypical antipsychotics. So what do you do? What do you give them? So the only country that has looked at this and approved an agent was in Germany, and risperidone was approved. It's hard to completely avoid the use of antipsychotics in this patient population. And so the best thing to do is to kind of start the medication at low dose and raise the dose slowly. Next slide, please. So this is a very interesting study looking at QT prolongation. And as you can see that there are a number of agents that prolong QT. Droperidol is probably the one that causes the most significant prolongation, but you have olanzapine and Haldol and everything else prolonging it. the very interesting thing about this study is even though olanzapine and the other atypical antipsychotics prolong QT, we don't see torsades in these cases. However, the important thing of this slide is that if it is a young person with a family history of prolonged QT or sudden death, we need to think twice about giving them any of these agents that might prolong QT. Older patients that have known heart disease that are on type 1A antiarrhythmics also need to avoid these agents. And if the patient has hypokalemia, it will also predispose to QT prolongation. Next slide. Now this slide is from the Cochrane review, and it's a systematic review of the use of benzos in combination or alone. They looked at 11 studies, about 600 plus patients, and they compared benzos alone and found that versus giving antipsychotics, and they found the sedation equally prevalent, that fewer patients remained excited after 24 hours when they were given benzos, and it had a similar incidence of adverse events. When they looked at benzos versus antipsychotics, the problem is that antipsychotics have a higher incidence, of course, of extrapyramidal symptoms. So their recommendation is you probably don't need to do the Haldol-lorazepam combination. It should be one or the other because the incidence of oversedation is too high. Next slide. How about antihistamines? So first of all, I would never recommend antihistamines as a solo agent, as we discussed, both in kids and in elderly because of the paradoxical excitation rather than calming. The question is, do you need it to prevent acute dystonic reactions? The problem is there's no good study in the emergency setting where they looked at this. Most of the time, the patients that got acute dystonic reactions were on the meds on a daily basis, early on an initiation of long-term treatment, seen more frequently in males, and this also adds to sedation, and it may also cause some paradoxical agitation. So I conclude that there really is no good evidence for its routine use in the emergency setting. Next slide. This is another very interesting slide where the question is, if we give them, say, Haldol, and they're still agitated, do we give more Haldol? And if they're still agitated, we give more Haldol. What this study says is that some patients got more violent after repeated use of the agent. And they're not sure whether this was akathisia or drug-induced behavioral toxicity. So what this tells me is that if the patient gets worse or doesn't respond, let's try a different agent the next time. Next slide. This is a question of whether we should give oral or IM. It was a structured literature review in which 11 articles were reviewed. They looked at oral medication and thought it was as effective an IM in rapid reduction of psychotic agitation. So that's one of the etiologies. And they recommended risperidone with or without lorazepam or olanzapine. But in this study, they didn't include that one that comes kicking and screaming with the police holding them down. So it really didn't include that group. But what I do think this tells us is that we need to probably consider oral meds much more frequently than we do. Next slide. This is what we use in the Sinai Health System. And what you see on the left-hand side is the SAT scale, sedation agitation scale. It's on a +3, -3. So +3 is very, very agitated, like bouncing off the walls. -3 is hard to awake, arouse. 0 is what everybody in this room is today, hopefully. Maybe a few are in the -1, sleeping. And what this says is, and the docs have to put in a agitation scale before they can order any meds at all. So what you see here is that depending on their SAT score, it either leads you to giving PO meds. If it's low, if it's high, then give IM meds and maybe restraint. Next slide, please. So there are some newer agents being considered for agitation. Agitation is being used for agitated patients, especially in the unknown etiology of agitation. So here we see ketamine was given to 40 agitated patients in the field, and even patients that had head trauma, they used fairly large dose, 1 to 5 milligrams per kilogram, either IV or IM with no adverse events. I tend not to go to that high of a dose. I tend to give a sub anesthetic dose, starting with 0.1 or 0.5 initially, rather than that much larger dose. But it can be given in a larger dose. There are 2 interesting studies, just an aside, where they used it in suicidal patients in which they saw significant reduction in suicide ideation for 10 days, and also in depression, in which it significantly reduced depression in a population of patients given ketamine IV. Next slide, please. So let's go back to the 36-year-old male with schizophrenia brought in by the family because he stopped taking his medication. And he was getting violent at home. So the treatment of choice, we tried de-escalation, didn't work. We did a SAT score, and his SAT score was +3. The patient was given Haldol, lorazepam, and an hour later, so according to our protocol, every hour they're supposed to be getting a repeat agitation scale. And here, after an hour, it was 0. Next slide. So take-home points. So 1, when we talk about testing, most patients don't need routine testing, but testing is indicated for patients with new onset psychiatric illness. The use of a protocol like one I mentioned, there's other protocols. There's one that came out of Medical College of Pennsylvania and Philadelphia, help us decide as a team collaborating who needs testing and who doesn't. When we do our assessment, it's important that we do cognitive functioning, and we need to use a scale of agitation, based our treatment of agitation on the underlying etiology, and everyone shouldn't get the same thing, and use de-escalation whenever possible. Next slide. So before I go to answer questions, I wanted to put my contact information on the left-hand side. If you have questions after today, we will have time for questions now, but if you have questions afterwards, this is how you can reach me. And on the right-hand side, the talk is really sponsored by the American Association for Emergency Psychiatry. And we have a conference every year. The conference this year is December 13th to 15th in Scottsdale at the Hyatt Gainey Ranch. It's a 3-day conference. The first day is pre-cons. One is teaching emergency docs emergency psychiatry, concurrent with teaching psychiatrist emergency medicine. There is another program, pre-con, that first day, talking about improving care and getting patients out sooner of the emergency setting. As you see on the right-hand side is the textbook everyone gets, Behavioral Emergencies. It's a 2-day state-of-the-art conference, and there's a scientific session. So if anybody's doing any research in anything related to behavioral emergencies, please submit an abstract to us. We'd be thrilled. It's the only conference on behavioral emergencies and the only scientific session that addresses behavioral emergencies as well. Anybody that's interested, there's our webpage. And with that, I'm happy to answer questions. And I'm not sure exactly how we're going to do it, but I'll be listening and responding.
We don't have a microphone in the room, so I will restate questions for you so you'll be able to hear them this way. So any questions? Someone can start. There's a question about a reference by Dr. Larkin in the ketamine article about something about the validity of the research on that. Are you familiar with that, or any comments there?
Yes. It was a very interesting study where he gave 15 patients who came in with suicide ideation, and 13 of the 14 that finished the study did not have suicide ideation. 10 days they were in the hospital. I think ketamine will be used in many settings, but it is not, and I repeat, not state of the art today for treatment of ideation.
And other questions? Question is inhalable antipsychotics in the emergency setting.
Yes, Adasuve is the only agent where there is inhalational. It is loxapine. The patient has to be cooperative to do that. The advantage to loxapine, as Adasuve, is quick onset. So it's thought to take effect in about 10 minutes.
Dr. Wong? Question about paradoxical reactions in children, benzodiazepines versus antihistamines.
Yeah, so it is thought that some children will have a paradoxical excitation rather than sedation from antihistamines, and that's why it's recommended not to give that to children. We don't know which ones are going to get sedated and which ones are going to get agitated.
The question is, are benzodiazepines also implicated in that?
It's more associated with antihistamines. I'm not familiar with the frequency of benzodiazepines causing excitation.
Dr. Campbell? All right. In Chicago, is your EMS using pre-hospital ketamine, or are they looking at that?
No, they are not. They just started using intranasal Versed for agitated patients in the field.
Thank you. Any other questions? Well, there being none, thank you very much for your presentation today. We appreciate you taking your time, and have a good day.
Thank you all. Appreciate it. Bye-bye.
Bye-bye.